Hello everyone, I'm Dr. Umashri. Today we will walk through the small topic known as Achilles tendinosis. Uh, we'll know about some learning objectives by the end of this topic that to understand the anatomy and functions of Achilles tendon, to differentiate tendinosis from tendinitis, describe the key pathophysiological changes in Achilles tendinosis, to identify the clinical signs and diagnostic tools, outline the conservative medical and surgical management, and to compare ESWT, prolotherapy, PRP therapies, and develop the basic treatment approach for the affected patients. Coming to the anatomy, it is tender Achilles is the largest and strongest tendon which connects the calves to the heel. Calf is nothing but it's a composition of gastrocnemius and soleus. Heel is nothing but a calcaneus. It plays a major role for walking, running, and jumping. The blood supply for this tendinochleus comes from musculotendinous junction, osseous insertion, and paratenon. There is a hypovascular watershed area which is usually 2 to 6 centimeters above the insertion, which is mostly prone for the injury. This is a diagrammatic representation of tender Achilles attachment. Coming to the pathophysiology, it is a chronic degeneration. It is not an inflammation. Usually tendinitis is an inflammation. Tendinosis is a degenerative condition. What is the causes? It is due to microtrauma, failed healing, and poor blood supply, which leads to collagen disorganization, increased ground substance, which promotes the neovascularization and nerve ingrowth, which leads to development of pain. So what we supposed to do next in investigations? First, clinical examination. The pain is usually gradual in onset and activity related. By increasing their activity, the patient complaining of more and more pain and is associated with the swelling which is nodular in depth. So on palpation, it is tenderness present and thickening is also present, and pain with the plantar flexion. Arc sign is positive. What do you mean by arc sign? There is a palpable tenderness moves with the ankle motion. With the ankle motion, as the tendon moves, there is a palpable tenderness present, and a single heel raise pain is present. On what further investigations is done by imaging known as like ultrasound, MRI, and X-rays. Ultrasound usually shows the thickening and neurovascularity of tendinochleus. MRI usually shows degeneration, tear, and rule out the other causes. X-rays usually to rule out the any bony injury or any calcaneal stress fracture or presence of calcaneal bony spurs. Next, coming to the further management is done by conservative treatment, usually by RICE. RICE is known as rest, ice, compression, and elevation. Elevation, limb elevation. Limb elevation reduces the swelling, so decreases the pain. Followed by NSAIDs. NSAIDs usual for pain, and followed by the physiotherapy. Physiotherapy usually of eccentric exercises. It is known as Alfredson protocol. Stretching and strengthening exercise. Orthotics and activity modification is also done. How do you perform Alfredson protocol? First, ask the patient to stand on the step with the balls of the foot on the edge of the step. Next, ask his hands to grip onto the some support. Next, keep the knee both the knees straight. Then, using the both the balls of the foot, ask the patient to stand on the steps. Then, ask the patient to stand only on the affected limb with the balls of the foot. Next, slowly ask him to lower the foot by himself and using the only injured ankle. Then ask the opposite leg also to place in the same place and repeat the exercise. And this exercise can be done with the knees straight and as well as with the knees flexed. So, what are the medical and surgical managements other than the physiotherapies? Medical management is usually PRPs. PRPs are platelet-rich plasma. These are derived from the platelets, useful for healing. And other is a prolotherapy. Prolotherapy is dextrose injection which triggers the repair. And corticosteroids, usually they are pain relief but increases the risk of rupture. What are the other surgical modalities? They are debridement, which are usually if medical treatment is not effective, then followed by surgical treatment has to be done, like debridement, tendon repair, gastrocnemius resection, that means lengthening of the gastrocnemius muscle. Next, tendon transfers in case of severe cases and ruptures. ESWT. Let's discuss elaborately about the medical management like ESWT, extracorporeal shock wave therapy. It delivers the high energy shock waves to promote the healing at particular site. What is the mechanism? It induces microtrauma, neovascularization. It induces collagen synthesis. It is useful for pain relief. Usually, it should be done in 3 to 5 sessions, at least a part of 1 week gap. Next, we'll discuss about prolotherapy. Prolotherapy is a irritant injection to trigger the inflammatory response. Injection is usually combination of dextrose plus lidocaine. Needle technique can be done in blindly or in ultrasound guided. How does it function? It improves the collagen formation, pain, and function. It's usually done in 3 to 4 sessions for every 2 to 3 weeks apart. Let's discuss about it elaborately. Prolotherapy, it involves injecting a irritant solution, example dextrose, into the tendon to stimulate healing. How do you do? First, to prepare the patient. How do you have to select the patient? There are some indications and contraindications. Indications: if there is a chronic mid-portion or insertional tendinosis, then only you have to select the patient, or failed conservative treatment like rest, physiotherapy, and exercises. And contraindications are in case of active infection, malignancy, bleeding disorders, poorly controlled diabetes, or if he is allergic to the injected. Then informed consent. You have to explain the risk to the patient, like increase the chance of pain, swelling, infection, and decreased effectiveness, need for more time period of injections. Explain about the expected benefits like gradual improvement over the weeks. Then what do you do? How do you start? Equipment required: 25 gauge syringe to 27 gauge syringe, then 5 to 10 ml of syringe, 5 to 10 ml syringe. Injected most commonly used is dextrose along with lidocaine. Lidocaine decreases the pain while injecting. So we have to combine with lidocaine, that to plain without adrenaline. So use a disinfectant on alcoholic solution to clean the particular area, then inject it. How do you inject? There are two techniques. Without ultrasound you can do, that is blind technique, and other one is with ultrasound. Without ultrasound is make the patient lie on prone position with the foot hanging off the table. Then mark the particular area which is thickened. Then palpate it. Then around the tendon you have to inject in multiple sites. At least 0.5 to 1 ml of solution you have to inject around the tendon, not into the core of the tendon. It is called as peppering technique. The total volume you have to give is at least 3 to 5 ml per session. At least 3 to 4 sessions you have to do it. With the help of ultrasound also you can do using the ultrasound probe. Then it identifies the tendinosis area. By you can in ultrasound you can easily identify the hypoechoic and thickened area. There you can directly inject the irritant solution. Post, or what do you do for post procedure care? At least 24 to 48 hours of rest you should make the patient. Then avoid NSAIDs. Apply the ice packs. Ask the patient to apply the ice packs. Then resume physiotherapy after 3 to 5 days, so that pain will get subsided by the time. PRP. Next, PRP, platelet-rich plasma. Platelet contains growth factor, which generates the tissue regeneration. Injection into the tendon, it enhances the healing. It usually 1 to 3 sessions a week, 1 week apart. It is useful for effective for pain and function. A patient can increase the duration of his function. So the overview of the Achilles tendinosis treatment with the PRP, it accelerates the healing using blood platelets. Prolotherapy, it increases the tissue regeneration with the help of irritants. Extracorporeal shock wave therapy, it stimulates the tissue repair through the shock waves. Next, further we'll move on to the surgical management. Surgical intervention for Achilles tendinosis is considered when the conservative treatment fails only after 6 to 12 months of it. The primary goals are to remove the degenerated tendon tissue, to stimulate the healing, and to restore the function. The choice of the procedure depends upon the position of the tendinosis, like at the mid portion or at the level of insertion. The general principles of surgery are to debride or remove the degenerated tendon tissue to restore the tendon continuity, promote the neovascularization, decompress the surrounding tissues, use the augmentation if more than 50% of tendon is involved. First, coming to the mid portion Achilles tendinosis. It usually occurs 2 to 6 centimeters proximal to the insertion. So how do you manage? Either one, first option by open debridement. The incision is given longitudinally or curvilinearly. Posterior medial incision usually taken. Steps are to identify and to protect the sural nerve is the main goal. Longitudinal splitting of the paratenon and tendon, excise the degenerated and fibrotic tissue, stimulate the bleeding bone bed with the help of drill holes. Optimal is gastrocnemius resection if the calf is tight. Second one is minimally invasive debridement. It causes less soft tissue trauma and responsible for the faster recovery. Performed under ultrasound or endoscopic guidance. Uses small incisions and shaver to excise the degenerated areas. Next is flexor hallucis longus tendon transfer. If the mid portion is stored and more than 50% of involvement of tendon is present, then flexor hallucis longus tendon transfer is indicated. It is usually harvested and transferred to reinforce the Achilles tendon. As it is a tendon, it provides the dynamic support and helps in a vascularity. This is a diagrammatic representation of FHL transfer. This is a tendon Achilles ruptured part, and this is a FHL. This is a FHL portion. So in case you can combine the FHL with the tendoachilles, and both together you can insert onto the calcaneal tuberosity and fix it with the calcaneal screws into the calcaneum. The other one is debride the Achilles tendon stump and bring the FHL into the calcaneal tuberosity and fix it with the screws to the calcaneum. Deformity. Haglund deformity is presence of bony spurs which results in the which keeps the pressure over the bursa and Achilles tendon, and which causes the irritation and resulting in the inflammation of the bursa, and the patient usually present with the bump over the back of the heel. It is called as Haglund's deformity. Coming to insertion of Achilles tendinosis, it involves tendon insertion, calcaneal deposits often seen in Haglund's deformity. What do you do next? Debridement with reattachment. Incision is usually the central longitudinal or lateral approach. Steps: expose the insertion and expose the bony prominence which is usually seen in Haglund's deformity. Remove those bony prominences and debride it, and then reattach the tendon to the calcaneum by using the drill holes and re-anchor the tendon using suture anchors. So double row repair. It is usually used when large portion of tendon is detached. Double row suture anchor technique, like it is usually like a rotator cuff repair only. FHL tendon augmentation is done in this case also when more than 50% of tendon is involved. So what are the adjunct procedures? There are paratenon release for in case of peritendinous fibrosis. Usually for peritendinous fibrosis, then it causes tightening and decreases the movement, and usually patient will have pain. So to improve that, you can do paratenon release, gastrocnemius resection to reduce the tension. Then endoscopic calcaneoplasty in case of Haglund's deformity. Platelet-rich plasma injection intraoperative can use but not routinely used. So what is a post-operative protocol? As you are debriding and reattaching the tendon to the new area. So you have to do new tendon to the new area. So you are fixation with the screws or suture anchors. So usually have to immobilize the patient initially in plantar flexion at least for about 2 to 4 weeks. Then progressive weight bearing. When the pain and swelling subsides, then progressive weight bearing over 6 to 8 weeks. Then followed by physiotherapy, starts with early range of movements. Then plan for the strengthening exercises. Return to sports usually after 4 to 6 months. So what are the outcomes? Outcomes are usually success rate is 70 to 90%. If the patient maintains rest, immobilization, and gradually returning to the movements. Better results usually occurs in mid-portion tendinosis than the insertional tendinosis. Complications are usually the wound healing problems, sural nerve injury, re-ruptures, and tendon stiffness are most common complications. Thank you.